All right. Thank you all for getting back to your seats, and I'm very pleased for this part of our day where we're joined by two congressional leaders in healthcare reform. We're going to hear from both Dr. Mike Burgess, who's the representative of the 26th District of Texas. He's a member of the Energy and Commerce Committee, which has a lot of jurisdiction over healthcare. And prior to that, he was a physician in practice for quite a while, for 3 decades. He's been extensively involved in healthcare legislation, legislation on reducing costs and reducing regulatory burdens, legislation related to choices for Medicare beneficiaries, and Medicare physician payment, obviously. He's played a significant role in bipartisan efforts to promote food, drug, and consumer product safety as well. We are also very lucky to have with us Congresswoman Allison Schwartz, who has also played a central role in debates about health care, including debates about issues related to health professionals. She's the founder and co-chair of the Health Care Innovation Task Force, and she's actively involved in the ongoing development of new healthcare delivery models and how legislation can support that. She's currently deeply involved in efforts to reform the Medicare physician payment system, including repeal of the sustainable growth rate. Actually, both of you have sponsored legislation to address that problem. I'm very pleased to have both of you with us today for this event on clinician leadership in healthcare reform. And Dr. Burgess, if you don't mind, maybe I can start with you. You're a physician. You're directly involved in leading healthcare policy reforms as a member of Congress. How has your clinical background served you in Congress? I know you've actually written some about this.
Well, you're kind to mention that, and we can go into that in more detail if you like. But honestly, you know, you do stop and think that when you sift through some of these dense policy pieces or dense instructions to federal agencies, how would this have made my job easier in the treatment room or in the delivery room or the operating room? And the fundamental unit of production of the American medical system is that interaction that takes place between the doctor and patient in the treatment room. And does what we are doing legislatively add value to that? Does it make it faster, better, cheaper, smarter? Or is it only going to add additional layers of things that have to be completed before that patient gets the desired care or the desired treatment? And that is, you know, it's been one of the tough things for me to watch this. And I'll just tell you, you know, clearly politically I was on the other side during the last session of Congress. But I will share with you that I reached out to the transition team shortly after the election. I reached out to Chairman Waxman shortly after he was selected as the new chairman of the Committee on Energy and Commerce in January of 2009 and said, look, I didn't give up a 25-year medical career to come sit on the sidelines. Please call on me. Let's be involved where we can. There are plenty of places I can't go, and I would readily admit that. I don't know what I would have done, for example, if someone would have said, we know you care deeply about the SGR and you want it reformed. Could you help us with the public option, or at least not speak so harshly about it when it comes up? I don't know. No one ever tried. That was perhaps one of the big failings in all of this. And I understand that there were people who had been there for generations. There were 3 committee chairmen who'd basically been elected during the Watergate election when I was just a child. Well, maybe in college, well, maybe in medical school, but still, it was a long time ago. And these 3 committee chairmen had very set ideas of what they wanted to do to the healthcare system. Now, you know, I'm just taken back to 4 years ago when Newt Gingrich and Ron Wyden were writing in, I think it was the Annals of Internal Medicine, and Mr. Gingrich said, you know, most breakthroughs in health don't occur as a consequence of focusing on financing. They occur because of focusing on a new way of delivery, or perhaps a new way of delivering something that was previously delivered. And, you know, that's true. Last night I was having a meeting with the dean of one of the medical schools back home. He's a gastroenterologist by trade, and he reminded me that when he's about my age, when he was in training, everything was focused on the treatment of peptic ulcer disease. the resident going through a GI residency right now, I mean, that's interesting from a historical perspective. It's kind of like when I was in medical school, we were all brought down to a hospital to see the kid with diphtheria because we'd never see another kid with diphtheria in our clinical lifetimes. Things change, and you know that. I mean, the evolution happens. It's almost unstoppable. The problem is things up here tend to be sort of ground and rooted in cement, and people change very, very slowly or in a very unwilling fashion. And you referenced the SGR, we'll get into it, but the SGR is probably front and center in that principle.
Well, interesting to hear about how maybe focusing on the clinical issues can help break through some of that cement that you mentioned. I know, Representative Schwartz, you've been working hard on this too. You've got close connections and a strong commitment to the healthcare system and to improving it, and you've been involved in some very interesting healthcare work in Pennsylvania. You've got doctors in the family. How has all that shaped your activities in Congress?
I did go through medical school as a spouse, which we could talk about actually if you wanted to, about what it means to the family. But I also worked in healthcare for almost 20 years. In the mid-'70s, I'm dating myself here a little bit, for a fledgling prepaid capitated system. I was responsible for helping to develop the delivery system as we tried to see if we could actually do such a thing as change some of the delivery system to improve healthcare delivery for both the providers and for patients. And we had some success. I went off and started and ran a health center for 12 years in Philadelphia, and then got elected to state senate, where I did a lot of healthcare policy. So yes, there's no question being on the side of what is it really like to organize, to support, to be able to make a delivery system work, again, to provide the greatest quality health care and for patients and for all Americans. So I have some experience in doing that for 20 years, then did a lot of work in helping to formulate how does public policy support that effort, which is, I think, ultimately not only about the patient doctor relationship, which it does come down to, but is also how do we make sure that Americans have access to quality, affordable health coverage, because it's about the patients that you see and provide care for. But my guess is that some of the financing does enter into all of this. It isn't a completely pure system. You do have to think about and do whether this person can afford the treatment you're recommending. Can you get them to the treatment? Do you have the right providers to be able to offer it? Do you have the support that you need to be able to do that in all the ways that you could suggest to us, and you have. So I think we did some remarkable work in the last session, and things do change around here. I have to say the last year has been really different for me to be in the minority and to have really a very different leadership, and so things can change on a dime here too. So I feel very strongly, as many of you know, about supporting teaching in academic health centers, and the fact that we want whatever we do to be dynamic, to be responsive, and to have doctors and medical personnel in hospitals really be in charge of what is the best way to provide health care to your patients. That's very important to me. And so we do need to have a financing system, both public and private, that helps support that. And right now we as we see some changes in that financing, certainly under Medicare, and as a member of the Ways and Means Committee, I obviously weighed in on this in terms of Medicare. I am looking for bipartisan ways for us to support those changes. And we're really calling on clinicians and clinical groups to step up and embrace new ways of delivering care so you can be in charge of it, and that we can give you the tools from a financing point of view for you to be able to use evidence-based medicine, evidence-based practice to evolve these new models of care that enable not only physicians but all medical personnel to be able to do what they really want to do, which is to provide the right kind of care in appropriate time to help their patients be better, and for all Americans to ultimately, at the end of the day, see healthier outcomes. In the process, we'd like to save a little bit of money. That would be helpful to us to sustain public systems in Medicare and Medicaid, but also in the private sector, as we see the issue of economic competitiveness and the high cost of health insurance for our providers really being a drag on them in terms of their ability to create jobs and grow the economy. So as someone who cares about healthcare and getting good quality healthcare to my constituents, and to do that research and education. Philadelphia has a lot of, how many of you went to medical school in Philadelphia? I bet there'll be a few of you. So you know that is a big, that is an important part of our economy. Someone told me we'd train 1 in 4 physicians in this nation. That seems high to me, but even if it's off by some, it is actually pretty remarkable, the work that we do. And I think we want to continue to do in being on the cutting edge, not only of the medical science, but of the delivery system reform. And we want a payment system that supports that. Be happy. I'm always trying to work in a bipartisan way, and Congressman Burgess has been supportive of, for example, the SGR repeal. Look, this is a system that, as far as I can tell, I wasn't here when it was implemented, but was suggested anyway, or recommended or passed. But the idea was that, we don't really know how to do this. Doctors are really smart people. We're just going to cut your reimbursement, and you'll figure it out. And that kind of didn't work. So it didn't work for you, and it obviously didn't work for Medicare. So
it drove the volume part of the equation through the roof because we had to pay our bills.
So, and then there's a bit of chasing what is reimbursed, which is not what you want to do for patients either. So it has led to some overutilization, some utilization, and we know it's not working. So I support full repeal of the SGR, but even that's not enough. We need to replace that payment system with a new payment system that will understand that there needs to be a transition period for you to be doing the work you have to do and developing new delivery system, for us to learn from that experience over the next 5 years, and then to offer options, not a single. I actually don't think there should be a single model of reimbursement, but that there's offer physician groups an option of how you want to be reimbursed. And that will in fact improve quality, get greater value for our public dollars, and move us in a direction that we all know we're going in, which is really better, more coordinated care that actually gets people the care that they need and helps them be healthier at the end of the day. So that's what I'm working on. Love to see the super committee help us get there, but we're going to have to do it anyway.
Now, you've been involved in this for some time, and including in some bipartisan efforts, including a briefing that I participated in, where there did seem to be a lot of ideas on the table. And Dr. Burgess, earlier this year, the Energy and Commerce Committee had hearings on SGR reform, and there were a lot of physician leaders present there, some of whom were actually present here, who described some ways to get to a better payment system in Medicare and maybe save some money at the same time. What's your latest take on why this time might be different than all the usual last-minute short-term fixes?
Well, if you'd had this conference in the middle of June, I would have said I'm very optimistic that we're going to get this fixed. The debt limit discussion then intervened, and things went off the tracks. But you're correct, both committees of jurisdiction, Ways and Means and Energy and Commerce, had hearings for the first time since 2006 on repeal of the Sustainable Growth Rate formula. Both committees have hired staff specifically to deal with the Sustainable Growth Rate formula problem. And all of the air doesn't go out of the balloon at this point. Something will have to happen before the end of this year, and I feel comfortable that it will. If I ran the zoo, it would be a 3-year period of stability. If it turns out to be 2 years, that's still a victory. Anything less than 1 year is a failure. So with those broad parameters, I think something will happen before the end of the year. I personally don't think it happens in the Joint Select Committee. The Joint Select Committee is all about cutting. The SGR formula reform is all about the opposite of cutting. So I think the missions of those two things are quite different, and so the Joint Select Committee probably shouldn't be the one in charge of this. I don't think they can use up all of the pay-fors. Some are relatively obscure, and I'm not going to articulate them this morning, but there are some pay-fors to get us a period of stability past this year. And then the work that was done, the committee work, the hearings, the staff work that was done up until the middle of June when sort of the wind went out of the sails is still available to pick up and carry on and get this thing done. There's going to be, of necessity, there's still going to be a lot of debate that needs to take place, because right now the debate's sort of taking place in the committee rooms up in Washington, D.C., but as I go around the country and talk to doctor groups, there is far from unanimity of opinion outside from physicians about what the future should look like. And I think the one thing that's different this time than any other time that I've served on the committee, and I've been there now, this is my 4th term on the committee, but this time it was sort of like it was opened up to suggestions. Let's hear from you. I mean, everybody gets the fact that the SGR is bad and got to go. We don't need to hear that anymore. We all understand it. We get it. We're all in on that. But what are your suggestions? And so the various specialty groups have come to us. The AMA and the American Osteopathic Association have come to us and talked about what they would like to see, some things they're doing within their specialty societies. So I would say this is all a positive direction that things are moving. It's not going to be solved by the end of December, and that is a shame that we were given a 1-year reprieve in the lame duck session last year. I thought we could get it done. I miscalculated about how disruptive the debt ceiling debate was going to be. But for better or for worse, all of that will be past us, and there is still the work that the foundation has been laid to a solution to this, and I just encourage your participation. It is so important. And again, going and talking to doctor groups, I talked to 6 individual doctor groups last week when we were home or out doing district work, and yeah, I get all the complaints, but you've also got to come to the table with some solutions.
Maybe to follow up on that, and obviously there's a lot of attention on the SGR, but if we could maybe focus a little bit more on, you've had a lot of experience not only in the healthcare system but working with health professionals and others in trying to solve some of these very difficult legislative challenges. So I'd really like to hear, the question I most wanted to ask is, what would you tell physicians, nurses, other health professionals about the most effective way to get involved and influence this process? I'm picking up on what you just said, Dr. Burgess. It sounds like coming forward not just with talking about the problem and maybe not just saying, and I don't want to put words in your mouth, not just saying, we need to fix the SGR, but how, and how can you do it in a way that addresses some of these core underlying policy problems? I mean, we're operating in an era of big deficits and big concerns about government financing for healthcare more generally. A theme for our day is about how physicians and other clinicians can help lead that. What's your
well,
take?
first of all, I think that, and I think there are probably some representatives in the room, but we've worked very closely over the years, but certainly in the last few months in particular. A lot of the associations that represent physicians here, and there are many of them, have actually stepped up and put forward ideas about how to fix the SGR, for example, and how to move forward. And they've been very constructive. We've worked very closely with them, and as later today I talk about the framework which I just laid out to you earlier about how we do this, very consistent with what the AMA and the Osteopathic Association and the American College of Physicians and a number of the specialty groups as well have said they support. And again, the framework is basically a transition. I actually think we need more like 5-year transition rather than 2 or 3 to be able to really look at the models, and a replacement system with some understanding of what that transition really means. And again, a variety of models that work given the variety of practice settings and variety of the geography that matters as well. And so we've been working very closely, and in fact the American Osteopathic Association and the American College of Physicians have already supported my framework, and we're working closely on the legislation. AMA is close. They've been really very, very helpful and engaged, which I appreciate, and even the American College of OBGYNs. I mean, a number of, again, your leadership, your association here that really does drill down on how do you get this done, what do we have to say, what should the legislation look like. And to some extent, I will talk as well to individual physicians at home and nationally, and mostly they will share with me what some of the issues are as they see some of the problems, but they spend every day seeing patients. I mean, they don't come home and then say, okay, here's how I want you to reform the insurance system. Here's how I want you to, here's the best way for you to find the dollars. That's kind of our job to do. And I guess I will, many of us are very skeptical, and we are just a few days away from hearing from the Joint Select Committee. It is still possible for them to find a way forward to reduce our deficit and also meet our obligations in this country. I don't know if they get there. I certainly agree that we're going to have to fix the SGR and have a replacement, whether they do it in the super committee or not. But let me say this, it's $300 billion to do full repeal if we do it before the end of December. It goes up after that, because we keep not doing these reductions from our budgeting point of view. The way we do budgeting is it still is on the books as an expectation. And so we've got to do this. And the Super Committee is an opportunity for them to figure out how to pay for that and how to get it all, repeal it. And then that gives us the tools to be able to repeal it with and replace it with something much better for physicians in this country. So I wouldn't give up just yet. There is a chance. And even as we move forward towards the end of the year, if we have to do it on our own through the committee process, and I would agree with Mike that I have tremendous respect for our committee process, and I served on Ways and Means Committee. I'd rather be the one in the committee rooms having some say about this. Mark knows something about this, but there is a chance for us, because we do know what, I think many of us do have agreement about how to move forward. We really do. And I've been on panels. This is bipartisan. It's, again, I want to be sure it's flexible, that there's response, that we can learn from the experience over the next 5 to 6 years. That's enormously important. So your question as to how you can get involved, I think the most important thing for you to do at this point is to really examine how you think the delivery system could change, should change, to keep the tool, give you that responsibility to provide health care in a way that works for, again, for physicians, for providers, and for the patients you see. That is what the next 4 to 5 years is all about. I'm sort of saying to you, we want you to step up. We want you to explore these options. We want you to give feedback to the administration. They've been quite responsive. I think if you look at the ACO regulations, there was a lot of reaction to the initial ACO regulations, and they made significant changes because they want it to work. I want it to work. So I think what you do in the next few years will inform that payment system that replaces SGR. So I would ask you to step up and tell us what's working as well as what's not, because we want to replace it with a system that works. And that's where you really have a tremendous opportunity and maybe even responsibility.
Dr. Burgess, any further advice for clinicians like these?
Well, it is so good that you're doing this, and I remember now it's been 15 years ago when I went to a lecture about taking back medicine. I said, yeah, that's for me, let's take back medicine. And one of the individuals who spoke was a management professor from the University of Texas at Dallas. And I thought, what in the heck is this guy going to tell me that's worthwhile? And what he said was that doctors cannot, you have to develop the leadership expertise from within your own ranks. You cannot go and hire a consultant. You cannot put someone else to do this work for you. You have to develop the expertise within your own ranks. You can't farm it out. And I think he was exactly on point. That's why I'm so glad that you're doing this. Look, in my perfect world, we'd have vastly expanded consumer-directed health care for big sections of the population, but I also recognize that there are people who simply could not manage their health care existence in that type of world. Don Berwick has talked about 20% of his patients spending 80% of his money. He knows who they are. They're people who are eligible for both Medicare and Medicaid simultaneously. They don't move around a lot. The population is relatively fixed in space and time. So why don't we develop a better way of delivering care for this subsection of the population who could never be managed in a consumer-directed health plan? What they need is a doctor. They need a doctor to take care of them. You have doctors who are willing to do that. Now, the ACA response to this was to develop an entirely new federal agency, the Federal Coordinated Health Center, or whatever it is. But realistically, Tanya had broad demonstration project authority within CMS. Why not try? Whether you call it direct primary care, however, concierge physician, whatever you want to call it, but put somebody in charge of these patients' medical care, and I think you'll find care that's delivered in a timely fashion, in a much more cost-effective way, and the patients will get better care ultimately, and that's got to be the ultimate goal. So there are a variety of solutions out there. To say one thing is going to fix all of the problems, I think is preposterous, and that was, sort of the notion behind driving the ACA that I pushed against so hard. American medicine is multifaceted. Your patients are not all the same, and it is going to require a variety of approaches. works in Philadelphia will not work in Muleshoe, Texas. It's just a given. There are two different worlds, and they're going to have sensitivities to the differences of those worlds.
And I do want to say that, and you may have seen this, I think there is a lot of opportunity to offer a variety of options, and I'm sure you'll be talking about this during the course of the day. Just this week, CMS did come out with, we have certain models within ACA, but in fact, if you were thinking up doing delivery system reform in another way, and I hope you talk more about this later, we want to know about that. We're open to it. It doesn't have to fit into one of our regulations. It's just, I think the opportunity is it is not a one-size-fits-all by any means. There's just tremendous opportunity, and I think you'll hear more about that from Dr. Barron later. But it's, I was impressed myself that they're really open to private initiatives that are not publicly driven, and if they work, they can be incorporated as well. And I think that is an enormous opportunity. Again, it puts a lot back on you in a way to define what that is and to communicate again what works for you, and whether we can expand that. A lot of this is also about, there are good models out there. How many of those can we duplicate? How many can we scale up and make sure that we reach out to other patients and other populations across the country?
It does seem like a couple of common themes, that in order to get this problem really solved, a lot of the leadership is going to have to come from clinicians like you, that the solutions are going to be diverse, and there's some real work ahead to get that done. But that with the leadership from the clinical community, there's a real opportunity for some bipartisan action.
Hope so.
We have just we ask you to stay for just a minute or two more. Maybe time for one or two questions or comments from those of you who are here. We've heard a lot from both of these members already. Any final thoughts or questions from you all? Yeah.
I'm Jerry Friedman from the Ohio State University Medical Center. I want to thank you for your comments this morning. I'm curious about your views on the future of graduate medical education. Irrespective of what the solution is, we are seeing a looming shortage of doctors. We're being asked to train interdisciplinarily. Where does Medicare play into this? Medicare has, since its inception, supported the education of physicians. We certainly have medical students now who are concerned about whether or not they'll have a residency slot when they graduate. And the super committee has obviously got this on its agenda as well. I'd appreciate your thoughts.
Perhaps one of the failings of the ACA was it didn't address what you described as the looming physician shortage, and whatever the effects will be of vast expansions of Medicaid and huge federal subsidies in the exchanges, there will be more patients in the queue, and what will happen at the end of that queue is anyone's guess. I mean, I don't think the problem's been well studied. Now, there were some opportunities in the healthcare reform legislation that went through, and I think some of the things that, although I did not support the House version of the bill, there were some things on the House side that I thought were perhaps a little bit better structured as far as the funding, both the direct and indirect funding for graduate medical education. But they kind of fell off in the Senate bill, and now they are, I mean, the landscape is uneven, and I will readily admit to you that is a problem, and one that we will have to address. I mean, this is not something that can be fixed by anyone other than the people who actually write the checks at the end of the day in the appropriations process, but it does have to happen.
And one of the things that wasn't mentioned in my resume is I also started the Academic Medical Caucus within Congress, and it's bipartisan, and really appreciate support on that, and was a very vocal, both publicly and within the discussions around to be supportive of GME and IME and protecting the role of teaching hospitals and the mission of teaching. So while they also might be involved with some of the, and hopefully will, with some of the delivery system reform, I feel very strongly that mission of teaching medical students and residents is as expensive and enormously important. In ACA, as you probably know, we did redirect some of the unused residency slots. There were about, I think, 600 across the country to be used if the institution didn't want to use it, to give it direct them to other institutions that would actually fill those slots, with some preference for primary care. Because of the need for primary care physicians. We also do some other things on primary care, as you may know, in terms of enhancing reimbursement. But and I have since then continued to be a little bit of a, I do other work, and SDR has been kind of my one note recently, making sure I also say, don't forget, do not interfere with GME and IME. It's enormously important to have some stability for the teaching hospitals in knowing that support for medical students and residency is really important. I do have a son who's finishing his cardiology fellowship and a daughter-in-law who's finishing a residency in pathology. So I'm well aware of, of the next generation of physicians, all of whom are asking about what's next, obviously. But committed again, as I think that we start out, to patient care and to research and advancement, and to what's going on in healthcare in this country, and committed to that. So we need to make sure that I think there is a real shortage of physicians, and we've ignored some of that in terms of whether we should have new residency slots. I'm also working on some language legislation to see how we actually might, in fact, if we're talking about, some people think we need 15,000 more residency slots in this country. So, I mean, it's just how do we do that? How do we pay for it? How do we protect that mission? And so, again, if you work in an academic medical center, or all of you came through one, to really make sure that you talk about that as well. There are other goals and missions in the healthcare arena, and teaching and preparing the next generation of physicians is certainly one of them.
Well, thank you all for the comments. I'm sorry I have to cut this off. I know we've got a busy day. You all have a busy day. Clearly, a lot of opportunities for clinician leadership in helping at what is sounds like a critical phase of not only reforms for physician payment, but reforms affecting academic medical centers and other parts of our healthcare system too. I'd like to thank Representative Schwartz, Dr. Burgess for joining us, and really appreciate your thoughts to get us started on the discussion today. Thank you.